Good morning, everyone. A warm welcome to all. On behalf of the program committee, I extend my appreciation to each of you for traveling from far and wide to join us. We hope that you will enjoy the fabulous weather and the beautiful surroundings while you are here. The program we offer you this year is spectacular. It had to be to compete with the fabulous weather and beautiful surroundings. And to prove that it is indeed fabulous, it is my honor and my delight to introduce the first of our keynote speakers, Susan Whitfield-Gabrieli. Susan is the consummate brain mapper. She's a perfect triple threat in our field: technically expert, clinically astute, and committed to sharing. Using her technical academic training in physics and mathematics from the University of California at Berkeley, she began her career in the laboratory of Judy Ford, a clinical psychologist who was using EEG to study people with schizophrenia. Together with Judy, a fabulous mentor, and her Stanford colleagues, Sue quickly became expert at EEG data analysis. With the introduction of fMRI into more widespread use, they adopted it in the lab and her attention shifted to that modality. Sue's fundamental conceptual understanding of the physical properties of brain imaging data and the sources of both signal and noise in that data allowed her to not only use the available software tools, but also to extend them or build new ones to improve the signal processing when there were components missing from existing tools. Many of you are now using her tools, such as her ART package for detecting and adjusting for sources of noise in fMRI data, or CON for performing resting state connectivity analyses. You can find these on the nitric.org website, where they have been downloaded more than 25,000 times. NITRIC, which stands for the Neuroimaging Informatics Tools and Resources Clearinghouse, is a resource you should all know about. Check them out while you're here. They're in booth 122. Sue sets the bar appropriately high for best practices in data analysis. The quality of her work is clear validation of their value. Sue has developed and maintained productive collaborations with outstanding cognitive and clinical neuroscientists with whom she investigates fundamental neurobiological processes underlying severe neuropsychiatric disorders. Her work has advanced our understanding of the pathophysiological processes in, to list just a few, schizophrenia, ADHD, anxiety disorders, disturbances of consciousness, as well as providing key insights into normal human development. With more than 100 manuscripts, many in top journals such as Science, Neuron, Nature Neuroscience, PNAS, as well as JAMA and American Journal of Psychiatry, it is clear she's a leader in her field. Among her many accolades and accomplishments, I personally value her commitment to teaching and education. Not only does she freely share all of her software tools with the scientific community, as an individual she provides an unparalleled level of support for them. As I look around this room today, I know that many hundreds of you have benefited from her teaching, either directly or indirectly. She's a consummate teacher, whether in one-on-one sessions with students and trainees, in small groups, workshops, courses, or these large lectures. She succeeds in making even the most expert among us think more deeply about our work, while enabling even the newest learners among us. So it is with great pride that I introduce my dear friend, Susan Whitfield-Gabrieli, to you to deliver her lecture on Connectomic Insights into Psychiatric Disorders.
Well, thank you, Randy, for that amazing introduction. It's wonderful to have you as such a fabulous friend and colleague. I wanted to also thank the HBM organizers. It's truly a pleasure and an honor to be here. I want to thank you all for coming. I'm really excited to be at HBM today. So as Randy had said, I'll be talking about Connectomics Insights into Psychiatric Disorders. For years, we've looked at lesions, neuropsychology, neurotransmitter manipulation, and more recently, neuroimaging techniques. And each advance in human brain mapping has led to phenomenal insights into the human brain. And today, I'll talk about how Connectomics, and by that I mean the intrinsic functional architecture of the human brain, as revealed by resting state functional connectivity, holds great promise for clinical translation, specifically to neuropsychiatric disorders. If you were to look at PubMed, there's approximately 17,000 neuroimaging papers related to major psychiatric disorders, including schizophrenia, depression, anxiety, autism, ADHD, dyslexia, and OCD. And we've learned a lot from all of these papers, and we've learned specifically brain differences of psychiatric disorders. And however, this knowledge actually hasn't fundamentally changed or altered patient diagnosis or treatment, except for a few examples where we do deep brain stimulation or TMS. So we have great challenges in psychiatric disorders. The etiology is unknown. Diagnosis is still based on symptoms. And very importantly, detection is often too late to substantially alter the trajectory of the course of the disease. Detection is actually done by crisis. And moreover, treatments are often based on trial and error, even though we know that there's large patient heterogeneity in treatment response. In addition, these treatments are only partially effective. When we think about the STAR study, that was one of the largest studies to evaluate treatment in depression, where they looked at 4,000 outpatients ages 18 to 75, only 50% of those patients responded. And people have shown that treatment response is similar for cognitive behavioral therapy. And because it's only partially effective, there's often high attrition associated with these treatments. So today I'll talk about how resting state networks offer clinical promise. I'll also talk about the methodological challenges that they incur, and I'll specifically be talking a lot about the default mode network. And in that context, I'll talk about the functional associations of the default mode network and self-reference networks, as well as the behavioral correlates of the default mode network. And this is an attempt to aid our interpretation of what pathology of the default mode network might mean in the case of neuropsychiatric disorders. Then I'll turn to talk about how we can use resting state networks in terms of clinical characterization, early identification, which could promote early intervention and perhaps prevention. I'll also talk about how you can use these resting state networks in terms of neuroprognosis or clinical prediction. And this is an aim towards precision medicine. And then I'll shift a little bit and talk about how we can modulate these resting state networks in terms of pharmacological or behavioral interventions. So it was back in the 1990s that Brat Briswell found the seminal finding that the regions of the brain that are highly temporally correlated to the motor cortex during rest are actually very similar to the task activations that we get with bilateral finger tapping. So in other words, the regions of the brain that rise and fall in temporal synchrony during rest elucidate an intrinsic network. And these intrinsic, spontaneous, extremely low-frequency networks of the bold signal exhibit networks in the absence of any task whatsoever. And I show you here a plot from Bazaki and colleagues in 2004, which shows you the linear relationship with frequency bands with which we're used to seeing from MEG and EEG, that gamma, alpha, beta, theta, and delta. He coined 4 new frequency bands: slow 1, slow 2, slow 3, and slow 4. And here we're looking at bold fluctuations, really in ultra-low frequencies in slow 3 and slow 4. Now we know that there's many different resting state networks. However, today I'm going to be focusing on the default mode network. So there's a number of interesting characteristics of the default mode network, or the resting state networks in general, that are extremely relevant to pediatric and clinical populations. Probably the most important of which is there is no task. And that's really important because you bypass behavioral differences in task performance. You obviate all the confounds that you usually have in task-related data. And that it's also accessible to pediatric populations, including infants. And it's accessible to a wide range of clinical populations, including low-functioning ASD. Many people have also shown that these resting state networks can be fairly reliable, robust, and they're also plastic. And this allows us to look at how pharmacological and behavioral interventions can modulate these resting state networks. Thirdly, they're easy to acquire large databases. And this is really important for clinical translation because we need these large databases in order to create reliable models for clinical translation. So originally we used neuroimaging to identify regions of the brain that were more active for a particular task relative to a baseline or rest condition. However, if you were to flip the question and flip the contrast to ask what regions of the brain are more active during rest, when the subject's mental processes are completely unconstrained, and you might be thinking about global warming and when can I get my next coffee break, you might imagine that the brain activations will be quite variable. But as we know from Mark Rakel's seminal finding in 2001, the brain regions that are more active during rest relative to a wide variety of attention demanding tasks are actually remarkably similar. And of course, as we know, that's the default mode network. Comprising mostly of the MPFC, the medial prefrontal cortex, posterior cingulateral parietal cortices. But now we also know that the same exact network can also be elucidated by simply looking at the temporal correlations during rest. And because of these findings, the field of the default mode network as well as resting state networks has exploded, as you know. And it turns out that 14 years later, 3,000 DMN papers later, Mark Reichel published another phenomenally beautiful review of the default mode network, in which the first figure shows a graph analysis of these publications. And you can see that the region, the cluster here in blue, shows you all of those papers that talk about disease related to DMN. So this is an iconic figure from the Fox 2005 paper where he showed that the brain is intrinsically organized into correlated and anti-correlated networks. And here he had the subjects just resting in the scanner. He placed a seed in the posterior cingulate and looked at the temporal correlations of every other voxel in the brain to that seed. And you can see here that regions that are anatomically distinct, like the medial prefrontal cortex and lateral parietal cortices, are actually highly functionally coherent. Of course, this is elucidated in default mode network, so that if you were to plot the time series of PCC or MPFC in yellow and orange respectively, they're practically superimposed. They're rising and falling in temporal synchrony. Now, it's not too surprising that this method of seed-driven resting state connectivity can elucidate the default mode network. After all, the subjects are just resting. However, he also showed that there's an anti-correlated network shown here in blue, and these are in task-positive regions. So any voxel here depicted in blue is negatively correlated. It's anti-correlated with the DMN. And it turns out that the this magnitude of the anti-correlation is extremely meaningful. And of course, it varies over time and across individuals. And today I'll talk a lot about how the anti-correlation with the medial prefrontal cortex, which is a node in the default mode network, and the dorsolateral prefrontal cortex, which is a node in the executive function or frontal parietal network, can offer great insight into neuropsychiatric disorders. Specifically, there's evidence to suggest, which I'll share with you today, that the MPFC, DLPFC anticorrelations are related to individual differences in executive function. They change over the lifespan, and they're significantly decreased in psychiatric disorders with cognitive impairment. However, to be able to actually interpret these positive and negative correlations, we have to address some critical methodological issues. And the two biggest methodological issues are that of physiological aliasing in these low-frequency components, as well as motion artifacts. So back in 2006, Byrne and Bandittini showed that the resting state networks are contaminated by respiration artifacts due to physiological aliasing. However, since the global signal of the brain correlates with respiration-induced artifacts, you can simply regress out the global signal, and that will reduce the false positives and leave you with a nice DMN that you're actually interested in looking at. However, in 2009, Murphy and Bandittini also showed that when you do global signal regression, you shift the distribution of correlation coefficients over such that the sum of the correlations have to add up to less than or equal to 0. In other words, this mathematically mandates the negative correlations and renders them uninterpretable. Later on, Ziad Saad showed that this method of global signal reduction also alters within and between group interregional correlations. And since we were really interested in interpreting these anti-correlations, we decided to use another method of noise reduction. So we found a method by Bazzotti and colleagues in 2007, which is the anatomical comp-core method of noise reduction. And in this method, what we do is we take the brain, we segment it into gray, white, CSF, and then we do a PCA decomposition of the white matter in CSF, and we remove these as nuisance parameters in the first level GLM. But we wanted to do an empirical study of the difference between global signal regression and anatomical comp core. So we took 15 healthy subjects. We did a 10-minute resting state scan. We chose a seed in the MPFC that was based on the peak coordinates of the Fox 2005. And we compared what the data would look like using the standard, meaning global signal regression, versus the anatomical comp core method. All the other processing, the standard processing were the same, except global signal regression and the anatomical comp core method of noise reduction. And what we found is a number of things. Here you can see to the left are the iterative steps of noise reduction. And here in the middle, what you see is the resulting connectivity map of the MPFC. And to the right, you'll see the distribution of correlation coefficients for each one of these noise reduction steps. So when you bandpass filter the data, you can see that every voxel in the brain seems somewhat correlated to the MPFC. So it's full of false positives. You can see the distribution of correlation coefficients here are all positive. When you do motion regression, not much changes. You might see a slight shift of distributions, But it's not until you really do global signal regression that you get a dramatic decrease in these false positives and a mathematically mandated increase of anticorrelations. So you can see the shift, a global shift of these distribution correlations roughly centered around 0, and again the sum is less than or equal to 0. But we were interested in what might happen with the CompCore method. And when we use an anatomical CompCore with this PCA of 5, we also saw a dramatic decrease in false positive. And we also saw some anticorrelations, which was great because we can now actually interpret them. Upon further inspection, we also showed that this method of the anatomical CompCore increases sensitivity and specificity. So because of this empirical study, we decided to use this method. And the second big methodological issue in resting state connectivity and fMRI in general is that, of course, of motion artifacts. Back in 2000, it wasn't the standard routine to do automatic or quality assurance in fMRI data. However, since I come back from an electrophysiology background, it's really imperative to detect outliers and deal with these outliers in EEG. So I tried to develop an artifact toolbox that would do the same thing in fMRI bold signal, and this is called ART, where we simply look for outliers in the global signal intensity as well as motion, and then we remove those outliers in the first level GLM. So we're usually using this ART toolbox for fMRI task activation studies, and that worked quite well because what it does is it reduces the unexplained error and increasing your t-stats where you would expect them. However, since this artifact toolbox came into existence, there's been a number of wonderful studies by Van Dyke and colleagues and Power and colleagues showing that motion actually has an even more insidious effect on resting state functional connectivity. And in fact, Power showed that specifically you can increase the anterior-posterior correlations by what he calls scrubbing or getting rid of the outliers in this global signal and motion. We found the same thing, and this is particularly important if you're wanting to investigate the default mode network, especially in pediatric or clinical populations where you tend to have more motion. So here's an example of a 10-year-old child, and here we have the ART toolbox. We're detecting a few outliers detected by global signal intensity as well as motion. And we want to ask the question, does this 10-year-old child have a default mode network or not? So we place a seed in the medial prefrontal cortex, and we look at the percent bold variance explained by the motion parameters only. And then we looked at the percent bold variance explained by motion parameters and outliers, and you can see there's a lot more variance explained. How does that transform into the connectivity map? Quite directly. So if we were to just regress that motion, we would conclude that this subject, this 10-year-old child, does not have a default mode network. However, if we regress that motion parameters plus a few artifactual covariates, you would see that actually indeed this subject does have the default mode network. And specifically, again, it augments anterior-posterior correlations, which is very important for the default mode network because it's precisely the MPFC, PCC, and lateral parietal components of the default mode network that we're very interested in looking at. And so I'm showing you an example of a single subject case here, but we've also seen this in many group analyses, one of which I'll share with you here. This is a study where we looked at the development of the default mode network, where we were looking at individuals, 86 individuals ranging from 8 to 24. And we took the core hubs of the default mode network, MPFC, lateral parietal, PCC, and right lateral parietal. And what we did was we did a whole brain correlation of the DMN with age. And what we found prior to artifact rejection was that there seemed to be an increased correlation both in the positive and negative correlations with each of these seeds. However, after artifact rejection, it was only the negative correlations that increased with age. The positive correlations were no longer significantly related to age. And I believe that's primarily because the children move more and you have more artifacts. So we developed a toolbox called CON that implements both the anatomical CompCore method of noise reduction so that we can interpret these anticorrelations, as well as the artifact detection and rejection routine that I told you about. So all of the studies that I'll talk about today have gone through this anatomical CompCore method of noise reduction as well as motion artifact rejection. So we've already addressed some key methodological issues that would limit interpretation of the DMN. What do we know about the DMN that would actually facilitate interpretation in the functional pathology of this network in the context of neuropsychiatric disorders? There's a couple of things I want to mention. One is that there's a functional association or overlap between the default mode network and the self-reference networks. We did an empirical investigation looking at this overlap using the same subjects with the same semantic baseline. So what we did was a conjunction analysis, looking at where in the brain the regions are more active for a self-reference relative to a semantic baseline, as well as more active for rest relative to a semantic baseline. And it was precisely the two medial hubs of the default mode network, namely MPFC and PCC, that were conjoined. So that might aid in interpretation if these two particular hubs of the default mode network are aberrant, or if there's a functional pathology in these nodes in the default mode network, and may be related to a functional pathology in self-referential processing. We also know that the default mode network is related to executive function. We know that in two ways. One, in task suppression. We know that in the healthy brain, the greater suppression of the default network is associated with better memory formation, increased task difficulty, fewer lapses of attention, better learning of cognitive skills, and less mind wandering, which should make you happier. So in general, the more these regions are suppressed, the better you can focus on an external, the world, and the better you can perform a task. But it's not just in the DMN task suppression that you see relations in executive function, it's also in pure resting state correlations. So if you look at the resting state correlations, you can see that greater medial prefrontal cortex and dorsolateral prefrontal cortex anti-correlations are related to superior working memory capacity. So what we did here is we had a group of 70 subjects. We placed a seed in the medial prefrontal cortex. We looked at the anti-correlations in the dorsolateral prefrontal cortex, extracted the z-values there, and then correlated it with complex working memory called OHBM. And it turned out that the individuals who had the most negative or anti-correlated regions between MPFC and DLPFC had superior working memory capacity. We've also shown this in speed of processing, fluid intelligence, and IQ. These anti-correlations tend to grow with age as executive function. They also decline at the other end of the life spectrum as fluid intelligence. So those are all correlational. What about causal? We also did a study where we looked at how the default network anticorrelations are causally related to sustained attention. And here we use real-time fMRI to trigger a stimulus of a sustained attention task based on the state of the DMN and SMA. So what we had here is the subjects lying in the scanner. We functionally localized the DMN and SMA, and then we tracked the bold signal from these two regions. And we detected what a good brain state might be based on if the SMA is high and the DMN is low. Once we detected that brain state as being good, we triggered a stimulus and the subject responded. We would continue to monitor in time the bold signal for both of those regions. And when we detected a bad state defined by the DMN being high and the SMA being low, we would trigger the stimulus and the subject would respond. And what we found was that there were faster reaction times for the brain being in a good state, in other words, DMN low, SMA high, versus a bad state, DMN high, SMA low. So this is an example where we use the physiological state of the brain, DMN anticorrelations, to predict subsequent behavior. So in conclusion, there's the two core medial hubs of the default mode network, namely the medial prefrontal cortex and the PCC, are related to self-referential processing. Secondly, the DMN resting state anticorrelations are in correlational causal related to executive function. And these are important things to keep in mind when we talk about the pathology of DMN in various psychiatric conditions. So let's turn to those clinical characterizations. The first of which I'll talk about schizophrenia. We know that schizophrenia is a severe psychiatric disorder characterized by disturbances of thought, perception, emotion, as well as cognitive deficits and working memory. We also know that there's a genetic basis for schizophrenia. And so we did a study where we looked at first episode or early patients with schizophrenia in order to minimize the potential confounds due to chronic medication. We also looked at first-degree relatives of patients with schizophrenia who were non-psychotic and non-medicated. And this offers a unique opportunity to relate the risk genes to behavior in the brain without the complexity of the disease. And finally, we looked at age-matched controls. And our question was, is there a functional pathology of the DMN in patients? And is there a functional pathology in the DMN in relatives? And quite surprisingly at first, we actually did see a functional pathology. The controls had a nice healthy DMN, but we found was that there was a monotonic increase in the resting state functional connectivity of the DMN from controls to relatives to patients. When we did an ANOVA, it was precisely the two core hubs that I was talking about previously that are implicated in self-referential processing, that the patients and the relatives were hyperconnected relative to the controls, both in PCC and MPFCs. The more of these two regions were correlated, the more psychopathology they had. So if you look at the connectivity or the resting state correlations between MPFC and PCC, you can see that the more these were pulled together or functionally correlated, the more positive symptoms they had, as determined by the global summary of the positive symptom score from the SAPS. So now let's turn from positive correlations to negative correlations. And so we wanted to look at the anticorrelations, both during rest and task, for all three groups. We seeded the medial prefrontal cortex. And controls, both in rest and task, had a nice healthy bilateral DLPFC anticorrelations, the relatives less so, and the patients not at all. When we did it in ANOVA, it was precisely the right DLPFC, BA46, where the controls, both in rest and task, had significantly more anticorrelation than the relatives and the patients. Well, what does this all mean? So I'm hypothesizing that perhaps this MPFC-DLPFC anticorrelation may reflect our ability to toggle between internal and external processing. When you're internal processing, you may be engaged in self-referential reflection, be doing future planning, past recollections, or if you have a brain disorder, you may be engaged in rumination, or in the case of schizophrenia, paranoid ideation. And when you're engaged in external processing, you may be engaged in external perception, keeping task-relevant information in mind. And so the magnitude of these anticorrelations may reflect simply the push-pull or toggling of going from internal to external processing. So in conclusion, we showed that patients with early schizophrenia and first-degree relatives have hyperconnectivity of the DMN, and that the greater DMN functional connectivity correlates with greater symptoms. So this is related to psychopathology. We also showed that schizophrenic patients and relatives had a reduction, a significant reduction in DMN anticorrelations, which is related to cognitive impairment. And the fact that we saw similar results in the relatives implies that this DMN functional pathology may be related to a risk or cause as opposed to a consequence of the disease. And finally, this increased positive correlations with self-reference nodes and decreased anticorrelations with executive function nodes may reflect an inability to allocate resources away from internal processing of thoughts and feelings towards external processing in order to adaptively perform difficult tasks. And it may blur the boundary between internal and external perceptions. So since this finding in 2009, there have been many replications. I'll just point out two. In 2010, Shim had a very nice study showing that they had hyperconnectivity as well as reduced anticorrelations. And Alan Atisevic also had a really nice study showing that first episode, 129 subjects, also had hyperconnectivity of the DMN. So let's turn to ADHD. ADHD is characterized by inattention, hyperactivity, impulsivity, and we know there's been an increase in incidence as well as an increase in drug treatment. And unlike many other psychiatric disorders, there is a chance to outgrow the diagnosis. In fact, 40% of the children with ADHD outgrow the diagnosis. But how does that work? And is there a biological distinction between persistent and remitted ADHD? So let's take a step back and think about what's been done in the field to date. Javier Castellanos has a beautiful study where he placed the seed in a PC seed and looked at the functional correlations of the PC seed to every other voxel in the brain, and the controls naturally had a nice healthy default mode network with anticorrelations in the cognitive control, ACC. However, the ADHD patients had a functional decoupling of the medial prefrontal cortex from the posterior cingulate, in addition to which they had a decrease in anticorrelations in the ACC. And that's with adult ADHD. So what we did was a longitudinal study where subjects were diagnosed at childhood with ADHD, and then we did a 16-year follow-up. Some were remitted, meaning they didn't meet the diagnostic criteria, and some were persistent. That means they still met diagnostic criteria. So we essentially had three groups: controls, persistent, and remitted. And importantly, the two different ADHD groups, persistent and remitted, were matched on IQ and executive function. So we had a couple of different questions. The first of which is, can we replicate the Castellanos study? In other words, will the persistent ADHD actually have this functional MPFC decoupling from the PCC? Moreover, will the remitted ADHD look like controls? Will their brains be normalized? Or would they look like persistent? And what we found was, first of all, we placed a seed in the PCC exactly as Javier Castellanos did, and what we found was the persistent actually did have a decoupling of the MPFC with the PCC, but the remitted actually did not. They had a nice coupling with MPFC and PCC, just like controls, and in fact, there was a significant increase in MPFC, PCC correlations with controls greater than persistent, as well as remitted greater than persistent. And what this tells us is there are two things. One is that because we replicated Castellanos' study showing that the persistent ADHD really does look like the adult ADHD, we really formed a syngenetic continuity between pediatric and adult diagnosed ADHD. That's the first thing. Secondly, because we showed that the remitted actually looks like controls, we showed that the DMN actually tracked the current diagnosis of adult ADHD, and this really provides a neurobiological convergence with the diagnosis of adult ADHD. However, the remitted ADHD were not exactly normalized. There are differences, and the differences are in the fact that both ADHD groups, the remitted and persistent, did not have the DMN anticorrelations. So although in controls, when you look at the MPFC seed, had the nice bilateral DLPFC anticorrelations, neither the remitted nor the persistent had those anticorrelations. And when we looked at the relationship between the anticorrelations and executive function as measured by the brief, here the brief lower values mean better executive function, and you plot the anticorrelations across all three groups, where the black are the controls, the blue are the remitted, and the red are the persistent, you'll see that the more these regions are anticorrelated, the better executive function they have across the groups. So in conclusion, the longitudinally followed sample with a childhood diagnosis of ADHD showed us that the persistent group, relative to both the control and remitted groups, had significant decreases in the MPFC-PCC correlations. In other words, the DMN tracked the current clinical status of adult ADHD. Secondly, the remitted and persistent ADHD relative to the controls had significant decreases in the DMN anticorrelations, as well as executive function, so they weren't completely normalized. And the reduction of the DMN anticorrelations may reflect the developmental history of ever having ADHD during childhood, as well as the lingering executive impairment they suffer. So now let's shift from clinical characterization to early identification. And this is an important topic because if we can identify subjects early who might be at risk, either familiar risk or clinical high risk, we may be able to potentiate early interventions and then hopefully prevent disease. So in depression, a child with a parent with major depression has a 3 to 5-fold increase of developing major depression. So here we decided to look at 30 children ages 8 to 14 who were at familiar risk for depression, meaning they had a parent with major depression, who were unmedicated and undiagnosed with depression. We also had controls age-matched with no depression. And we looked at a behavioral measure as measured by CBCL, which records behavioral problems and competencies in children of the same age range. But before I talk about the results of that, I want to talk about a beautiful study by Mike Grecius, where he showed in patients there's an increased DMN functional connectivity of the subgenual ACC in patients with major depression. So the DMN pulls in the subgenual ACC. And this is a beautiful study for many reasons. For one, we know that the subgenual ACC is highly implicated in depression, not only from Helen Mayberg's fabulous work, but also Drevitz and Dossanger, showing that there's decreased metabolism, there's decreased gray matter, decreased glial cells in depression in the subgenual region. So all this evidence is convergent on the subgenual region really being highly relevant to depression. So I really like this study, and we wanted to ask the question, is this DMN pathology in depression a reflection of the state of the depression or a neurobiological underpinning trait? So now that we have children at risk for depression, we can ask that question. So we placed the two seeds in the medial prefrontal cortex and the posterior cingulate, and we looked at the resting state connectivity to those seeds. And what we found was exactly the same thing, that the subgenual ACC was hyper-connected to the DMN for children at risk. They weren't actually depressed patients, they were only at risk, not clinically diagnosed. So they had hyperconnectivity of the DMN with the subgenual ACC relative to controls. Moreover, this hyperconnectivity related to an increase in internalizing score as related to the CBCL. So the more the subgenual ACC is pulled into the default mode network, the more these children were internalizing. So here we've identified task-independent functional biomarkers of risk for depression in children that could be used, hopefully to promote early intervention to reduce the likelihood of developing depression. Now let's shift from early identification over to prediction. So most prior imaging brain studies of psychiatric conditions, including ours, focus on brain differences in common among patients and relatives to controls. In other words, we're really capitalizing here on the homogeneity of patients. We're asking the question, how on average are patients with schizophrenia, depression, or whatever different from controls? So that really is talking about the homogeneity. But really we know that actually patients are very heterogeneous. There's a lot of heterogeneity in genetic, phenotypic, and environmental. And most importantly, there's a lot of heterogeneity in response to treatment, and that's actually key. So how do we predict who is going to respond to treatment? Well, there's a number of challenges in neuroimaging prediction in this way, especially if you're trying to predict the future. So there's a quote here, prediction is very difficult, especially if you're trying to predict the future. It's unclear whether that was from Bohr, Peterson, or Mark Twain, but it's true, it's hard to predict the future. We recently did a review where we looked at neuroimaging papers to predict outcome, and of the 72 studies that we found, 61 of these studies were actually correlational. And so what we really need to do is move from correlation to prediction. And of course, what we need for that is a very large N, so we have independent data sets to test our models, or we need to do lead-one-out cross-validation. So we need to go from correlation to prediction. The other question we need to keep in mind in terms of neuroimaging prediction and the clinical consequence is basically, does brain imaging add any meaningful increase in percent variance accounted for in the treatment response relative to other behavioral measures? So clinicians already have a number of behavioral measures which might predict clinical outcome. So we need to ask, can the brain imaging measures actually add a meaningful increase in percent variance accounted for by treatment? Otherwise, there's no point in doing brain imaging. So that's an important thing to keep in mind. The other thing is that a lot of these studies, including ours, are really post-diction, they're not prediction. In other words, all of these patients had already had their treatment, whether it's CBT or pharmacological intervention, and what we're doing is we're trying to use neuroimaging post hoc to see if we can, at baseline, predict who responded to what treatment. And hopefully in the future we can actually do real prediction studies. So social anxiety disorder is characterized by intense anxiety in social situations, avoidance of social situations, and it's one of the most common psychiatric conditions in the US. It's chronic and disabling, and it's associated with substantial impairment, decreased quality of life, and psychiatric comorbidity. Right now, the two major treatments for social anxiety are cognitive behavioral therapy as well as pharmacology. Although such treatments are superior to placebo on average, there's no reliable predictor of treatment response at all. So in this particular study, what we did was we take 39 medication-free patients with social anxiety disorder and 37 matched controls. We had the patients do 12 weeks of cognitive behavioral therapy, and at the baseline, we took fMRI task activation, and we took a diffusion weighted imaging as well as resting state data. And then we also had a clinical measure by LSAS, Liebowitz Social Anxiety Scale, so we know their anxiety levels pre and post. And for the fMRI task activation, we were looking specifically at the activation for angry, greater than neutral faces. For diffusion weighted imaging, we were looking at stratigraphy of the inferior longitudinal fasciculus. And for resting state functional connectivity, we did two different analyses. One was a hypothesis-driven, bilateral, anatomically defined seed-driven amygdala connectivity analysis, as well as a data-driven MVPA analysis. And what we found was the initial severity of anxiety alone already accounted for 12% of the variance in treatment response. So then the question becomes, well, if the initial severity already accounts for 12% of the treatment response, what can brain imaging add? Well, that is a salient question. Let's see what happened. Well, it turns out that the activation in this region, in the temporal occipital area, to angry versus neutral faces actually did predict clinical outcome. And if you were to add the fMRI activation with the initial LSAS, initial severity, the percent variance went from 12% to 41% variance of treatment response. So the brain imaging here actually did substantially increase the prediction. However, we're interested in moving away from task activation studies for all of the confound reasons, and we want to really understand how can intrinsic functional or anatomical connectivity use in this way for prediction. So we had two different resting state connectivity analyses. One was a hypothesis-driven, where we used bilateral anatomically derived amygdala, both from pre-surfer as well as a WFU pick atlas. And we did seed-driven resting state connectivity. That's because the amygdala is the most common brain locus of dysfunction in SAD. However, brain regions that are associated with pathophysiology may not be the same brain regions that predict treatment. And this is an important point because when we were initially looking at the fMRI task activation studies, we were assuming that the amygdala would predict clinical outcome, and that was not at all the case. It turned out to be this region in the occipital temporal area of the brain that predicted treatment response. So we also implemented agnostic data-driven multi-voxel pattern analysis. So this way, we're just, we do diagnostic analysis to see what brain regions are actually predicting clinical response. And what we found with the seed-driven resting state connectivity is that there were a few clusters that predicted clinical outcome, and amongst those clusters, there was one in the temporal occipital region, which was very similar to the one that we saw for the fMRI task activation for angry versus neutral faces that predicted clinical outcome. And because of this, we decided to focus on the inferior longitudinal fasciculus to do our diffusion tractography. And this inferior temporal occipital white matter has been associated with emotional valence of visual stimuli and has been associated with mediated fast transfer of visual signals to anterior temporal regions and neuromodulatory back projections to the amygdala to early visual areas. And so that seemed like a reasonable track to look at. And what we found was the FA along this tract increased according to increased outcome of the CBT. So in closing here, we know that the initial severity of the anxiety already accounted for 12% of the treatment response. So what did the intrinsic connectivity add? Well, quite a bit. When we combined connectivity from the diffusion imaging as well as the resting state measures, we found that 60% of the variance was explained in treatment response when you include all of these. And that's pretty phenomenal because it's a 5-fold improvement to what you would have with your initial behavioral assessment. So let's move from neuroprognosis to another question. We know that we've looked at ways in which we can use intrinsic connectivity to characterize different networks of different patient populations. We've shown that you can actually use these networks for early identification, and we've shown that you can predict clinical outcome. But what about modulation of these networks? Well, here's a study where we looked at pharmacological modulation of the default mode network in schizophrenia patients who had co-occurring cannabis use disorder. And it turns out that co-occurring cannabis use disorder happens in 42 to 65% of the patients with schizophrenia, which is quite shocking. And moreover, there's a vast literature that indicates that patients with co-occurring cannabis use disorder actually have better cognition than non-using patients. And that has been shown with working memory, attention, speed of processing, and verbal fluency. So what we did was we did pharmacological intervention where we had patients who have co-occurring cannabis use disorder come in as well as controls. For the patients, we had a baseline scan. They were abstinent through the entire study, and we checked them. And then 1 week later, we gave an intervention, which was either a cannabis, which you can see the bond here in the scanner, or a dronabinol pill. 3 hours after that intervention, we did another resting state scan. And what we found was, similar to the previous results, was that the schizophrenics actually had hyperconnectivity precisely in self-referential modes, MPFC and PCC. So the default mode network looked typical for the controls, but the patients with schizophrenia who had co-occurring cannabis use disorder had hyperconnectivity of these regions. And moreover, this degree of hyperconnectivity significantly correlated with positive symptoms. However, after the administration and intervention, this aberrant pathology was actually normalized. So there were no between group differences after the administration of cannabis and THC in the positive correlations of MPFC and PCC. But perhaps even more interesting In time 1, when we looked at the anticorrelations, we could see that the controls had a nice anticorrelation in the DLPFC. Again, the schizophrenic patients had none, so there was a big between-group difference. However, after the administration of both cannabis and THC, there was a significantly increase in DMN anticorrelations, as well as an increase of working memory performance. So that at the end, it normalized this pathology and there were no between-group differences. What's most interesting about this is that it not only increased the DMN anticorrelations, but it also increased the working memory performance. And we also saw that there was an increase, the increased anticorrelations significantly correlated with increased working memory performance. So in controls, the anticorrelations always significantly correlated with working memory performance, but in the patients, since they didn't have any anticorrelations at the beginning, there was no correlation to have, but after the intervention, you could see that the MPFC and DLPFC anticorrelation significantly related to the increase in working memory performance. So some of the conclusions here is that cannabis's normalization of the DMN may in part be attributable to cannabidiol, which has been shown to prevent psychotic symptoms and is actually being investigated as a standalone treatment for schizophrenia. And cannabidiol actually doesn't have the associated negative side effects that the currently available antipsychotic medications have, and may be a promising alternative pharmacotherapy for patients with schizophrenia. So conclusions here is the fact that the DMN is plastic and can be modulated by such pharmacological interventions offer hope that effective treatments such as these may help patients mitigate their symptoms, as well as potentially even augmenting cognitive function without the negative side effects. And finally, I'll talk about some cutting-edge technology that we're working on together, maybe perhaps some bleeding-edge technology where we're not looking at pharmacological interventions, but we're looking at behavioral interventions with real-time fMRI neurofeedback. What does that mean? So traditionally, you have some kind of cognitive emotional experiment which manipulates the mind, affects the brain. You look at your fMRI task activation. However, if you reverse engineer that and you ask the question, can people learn to regulate brain activation in a specific region or regions of the brain using real-time feedback from those regions? Well, we and many other people have shown, yes, you can actually train people to modulate their brain this way. But the more salient question really is, does learned regulation of the activation and correlations of these brain processes influence the mental processes mediated by those regions? And that's really the key question. So the way this works is you have people lying in the scanner, and you functionally localize many different ways. We did an ICA, so to localize the DMN and the executive function network. And then you instantaneously acquire the data, and you feed back the activation or correlations to the subject and train them to modulate this brain activation or correlation over time. And in this particular case, in the case of schizophrenia, what I'm hoping is that we can train patients with schizophrenia to upregulate their DLPFC, downregulate their DMN, and hence increase their anticorrelations. So what you see here on the left is the brain response in purple to the DLPFC and in green to the default mode network. And you can see that people aren't really able to differentiate those brain signals at the beginning. What you see here to the right is the feedback displayed to the subject. The goal of the task is to move this ball up into the yellow circle. And this ball will move up when the DLPO is high and the DMN is low. The ball will move down when the DMN is high and the DLPFC is low. So if you're increasing your anticorrelations, you move the ball up into the yellow circle, at which point it shrinks so that you can adaptively make the task harder. And we gave them a task, which is a mindfulness noting practice task, which helps diminish or decrease the DMN and subsequently increase the DLPFC, increasing the anticorrelations. So let's look at what that looks like. So here's an example of feedback of a subject doing this task. You can see he's moving the ball up. And look, he's able to increase the DLPFC, decrease the DMN, and actually attain a sustained anticorrelation between these two regions, which was phenomenally impressive to me. So this is, again, early work that we're doing, but the hope is here that we can potentially train patients with schizophrenia to increase their DMN anticorrelations with mindfulness meditation, and hopefully this learned increase in DMN anticorrelations will have a subsequent relation and decrease symptoms and increase cognition. So today I talked a little bit about how we can clinically translate intrinsic resting state connectivity networks, but I really want to ask a bigger question in terms of human brain mapping in general. In the future, is it possible that human brain mapping could facilitate children to get help before there is crisis through early identification? Could we treat more effectively with better direction, precision to available therapies? And can we use human brain mapping to provide optional, different, and novel therapies? Could human brain mapping help facilitate a path that will guide psychiatric patients or individuals at clinical and genetic high risk to happier and healthy lives? So I want to thank a number of people, including Mark Regel, who of course did the seminal findings with the default mode network, Bharat Biswal, who did the resting state connectivity, Mike Fox, who showed the intrinsic anticorrelations in the brain, as well as all of my clinical collaborators, Judy Ford, who's my mentor and co-collaborator, Larry Seidman, who I worked with the schizophrenia data, and Alan Green, who I worked with in terms of pharmacological intervention. Stephen Hoffman also was involved in the social anxiety. Judson Brewer was also involved in the mindfulness meditation. Alfonso Nieto-Casanan has been phenomenally helpful in developing a lot of these tools. And I also want to give a special thanks to the MIT collaborators. Joe Keller here is at the conference here. He was the one that did the individual differences of anticorrelations in relation to executive function. But he's also shown that there's a selective diminishment of these anticorrelations in aging. He has a poster that you can see here. Jenny Chai did a lot of the work with the CompCore versus global syndrome regression, as well as the development of the DMN. Aaron Matfield did a lot of the work with the ADHD. Satya Ghosh collaborated pretty much with everything, but he's done a phenomenal job taking over the real-time fMRI project in conjunction with Clemens Bauer and Kana Okana. So thank you. Any questions?
Hello.
I have a question. In the ADHD work, did you, with the people who are persistent, so the ones who remitted, was there any association between what they had received in terms of pharmacotherapy and whether they became remitted, and also their patterns of resting state activation?
So if I understand the question, so did the persistent group have any different therapy during the 16 years of follow-up?
Versus the remitted, yeah.
Right. So no, there was completely, pretty much everybody had the same medications. There was not any difference. There was not any difference at the baseline, and there weren't differences in the therapy.
Okay, thanks.
Yeah, I have a question. Hello? Over here to your, over here to your right.
So, okay.
Hi. Really great talk. It was awesome.
Thank you.
I'm wondering, you seem to be finding particular effects in the anticorrelation with default mode network and task positive, and sort of what we would think as two broad factors of clinical diagnosis.
Right.
So you have both ADHD as well as social anxiety. And I'm wondering how much you consider these to be specific deficits to the disorder, to the diagnosis, versus some larger latent factor of just psychiatrically impaired, and if you could speak a little bit to that.
That's an excellent question. So you're asking about specificity.
Yeah.
And so we've shown that both ADHD as well as early schizophrenics have an impaired DMN anticorrelation. And also, in addition to that, we've also shown that bipolar patients with who in their manic phase also have this DMN anticorrelation. So is there any kind of specificity? What we have seen is that early patients with schizophrenics have a very pronounced decrement in the DMN anticorrelations. And what we found is as you get more chronic into the disease, so chronic schizophrenics actually tend to have slightly less issues there, which could be an effect of the medication. So there is, in some way, lack of specificity because most of the populations that we see who have cognitive impairment do have a decrement in these anticorrelations. But if we look at other patient populations who don't have cognitive impairment, we don't see this anticorrelation difference. So the anticorrelation really seems to be related to executive impairment. So we seem to see a functional dissociation between the positive correlations of DMN relating to pathology of symptoms and the anticorrelations of the OPC related to cognitive impairment. So those diseases that have cognitive impairment usually have the deficit in anticorrelations.
Thank you.
Thank you.
So I don't think, oh, here we go. Thank you so much for helping us to all keep this field moving forward. Wonderful presentation. So it strikes me that if you want to get to the point where you're able to answer those last two questions that you had, we need to go from group analysis, comparing this group with that group of patients, to being able to do this in an individual subject.
Excellent question. So I didn't share this data, but we do logistic regression in all of these analyses, and that's really where you can get to the single patient point. And that's really where we need to move the field forward. And we showed in the case of the early identification with depression that the logistic regression had much higher sensitivity and specificity using the brain than using the CBCL. So that was helpful information. We also did a logistic regression with the social anxiety where we separated the groups based on the treatment response. But you're 100% right. We really need to take one more step to actually be able to predict on a single subject basis. And so
most pediatricians aren't going to be satisfied with a 60% predictive rate. So
right,
how do you propose to get from there to 95% sensitivity or specificity in the
right, so
diagnosis?
I can show you, actually I have all the sensitivity and specificity for all of the data that I just showed you. I did do this logistic regression, and I can show you that actually it outperforms the clinical measures. And so I do think that we're actually getting, it's a fabulous question, and I do think we are getting there. I can show you the data for that. Excellent. Okay, thank you everybody for coming. I'm told that it's time for the next talk, so thank you very much.